Lucindo. Hello, good day. Hey, good morning, Ike. Good morning, everybody.
Good morning, John.
Hi, John.
Good morning, John.
Hey,
Good
hey,
morning, John.
how you doing there?
Yeah,
Roberto? I don't know if you guys want to put your cameras on, Gautam, I don't know.
I'll come after 10. I'll come after 10 minutes, John. I'll come
Okay.
after 10 minutes.
Okay, we'll be here.
Yeah, sure.
Okay, very good. Very good. Okay, I'll be back. Roberto.
Okay.
Okay, Roberto.
Yeah.
Hey, Italy's getting better, huh? A little bit?
I actually don't know because yesterday I was looking to the dead people, to contagion, and I don't know.
Oh, okay.
Someone says that here in Lombardy is getting a bit better,
Yeah.
but in Italy, for me, is not. Now we cannot say anything. But listen, I read something about the fantastical Donald Trump that said that
Oh,
can you tell me something about it?
well, I'm afraid with him in charge. Um, I almost thought they needed a revolution to get rid of him. But they have people watching him. They have people in the government that, he does one thing and they go, you know what I mean? He's not the only one. Thank goodness.
Yeah. Yes. Yes.
Yeah, and they have people that check him and say, "Oh, wait a minute, that's not right." So I think we'll be okay as far as leadership. But I think he could do better. I hope he gets better. He's saying we don't need that many ventilators. The doctors say we need them. So whatever. Okay.
But what's your impression about the things that he said not to make the quarantine?
Not medical.
Quarantine.
Not medical.
No. What do you think about Donald Trump didn't apply the restrictions?
Yeah.
What's your personal?
My personal opinion, he's not doing the right things, the big things.
Okay.
Like equipment, getting prepared for equipment. They know it's going to happen, and he needs to take over and say, okay, now it's war. I can do what I want. And now it's war. He can do what he wants. He's telling General Motors to make ventilators. He's telling them, I mean, it's war. So he should have done that 3 weeks ago, a month ago, to get the equipment. And now there's a shortage of equipment everywhere, to test, for the gowns, for protection. We should be prepared because look what Italy went through. Look what these countries come on.
Yeah.
But he's entertaining. But not now. It's serious. It's like having a comedian, run a business. Okay, don't be funny now. Now it's time to work.
Yes. Listen, one other thing, not about the cover, but how couldn't you make you put the image behind you?
Oh yeah. Okay, go to the camera at the bottom of the Zoom. It says stop video. Next to that is a menu.
Okay.
Open the menu next to it. And then
choose virtual background.
Yeah. There we go.
Okay.
Well, you have a good background without the.
Okay. Background.
And then you pick a picture from your computer.
Yes. No. Then going to look.
But sometimes it's not good because. Okay, now you have to click on the video again. The camera. We cannot see your camera.
Yes, I know because I'm choosing.
Okay. Okay.
The right background.
Oh, okay.
I want to just give a look.
Okay.
I chose one stupid, a stupid one.
It's all right. Just see how, hey, that's good. That's good. You see it, right? That's the prime minister and a chicken.
Okay, also try.
I think you're gonna lose credibility. I don't know if a patient's gonna want to see you.
Was too funny.
Yeah, your background, you don't need a good background. You have one with the artwork.
Ah, yes, but
Good morning, Chandra. Okay, let me unmute you there, Chandra. How you doing today?
Good, thanks.
Very good.
Been a little busy in the hospital today, but
Okay.
nothing.
Okay. Yeah, I here. We start in about 3 minutes. Okay.
Yep.
Okay. I'll be back.
We have some colleagues. Yes, I think Roberto is here and a few
Yeah,
more.
you can see.
Well, I'm here too. I'm here too, Chandra.
Great type.
I wouldn't miss your lecture for the world. So I'm working from home, but I'm at home, but I'm definitely here.
Great.
That's right. Chandra can do as many as he wants.
I thought I would restrict myself to the hydrocephalus today,
Okay.
then see how things go further.
Okay. How are things in Nepal, right?
Well, the lockdown is continuing. We don't know how many cases we've got even. The state next to us, Bihar, is fighting it out. So we really don't know how many has got in. We really don't know. We have absolutely no idea. Let's see how it is.
Are you working out? Are you exercising?
I am.
Yeah,
I
you
am.
are.
Every day.
Oh, good. Okay.
Official figure in India today has jumped to about 1100. Addition of about 100 people every day.
Yeah, but the deaths are not very, death rate is not very alarming, you see.
It's still below 40.
Yeah. So what I think is it's not as dangerous as what is seen in Europe. I think it's going to be a bit less than what we are seeing rest of the world. The death rate, of course, the infection positivity and all that would be there, but I don't think the death rate is going to be as high as we've seen in UK, Europe, and the rest. I mean, even in China.
That's what everybody feels. The reason is probably unknown, as you say. It may be the virus is mutated to a milder degree, or there is some inherent immunity Indians have. I don't know. But right now there is a big exodus from big cities to small cities because of the lockdown, and that is not very
Conducive.
good.
Yeah. Did you hear what the president of Burundi of Africa said? He has 0 cases, and they asked him his secret. He says, "We don't test."
Yeah, Florida seems to be almost immune to the disease right now.
That's good.
Yeah, Africa seems to be doing pretty good.
Okay, we're going to start. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. It's Dr. John Bennett from the shores of Miami Beach in Florida. We are broadcasting the daily dose of neurosurgery education with Chandra Deopujari, noted Indian neurosurgery educator, as well as endoscopist and skull-based surgeon.
Pretty good.
Okay, we're going to introduce the guest first quickly. Okay, could you please introduce?
Thanks for the introduction, John. I like to think myself of more of a general neurosurgeon, species which is on the decline right now. But yes, we brought up when specialties have been just developing, so we've had a chance to dabble in everything. So let's talk about endoscopy for hydrocephalus. What's the current status? of the technology. And it was not until Vesalius published his work on the ventricles and tried to tell us as to what was the fluid circulation like. We all believed that, you know, taking fluid out from brain was taking out evil, etc., etc. And the pathophysiology of CSF circulation uh, became more and more clear. The idea of the fact that it was just diffusing out rather than having a particular pathway was also discovered only during this time. Though, as many of you must be knowing, that there is a theory of bulk flow which probably goes through these main channels, and uh, there is an alternative passage, or what is called the invisible flow, which goes from various other sources into the subarachnoid space, as is being discovered with every passing day. There's a beautiful article by Ashoff in Neurosurgical Review, which takes you through the whole development of how hydrocephalus was diagnosed earlier, the Greco-Roman explanations to begin with, who mainly dealt with this, what benefits the lumbar puncture gave, and what it taught us about CSF circulation. And in fact, as early as 1908, ventriculostomy without implants was discussed, though was abandoned very quickly because of high mortality. The modern technique has developed of endoscopy with the development of cystoscope, which people tried to put in the ventricles from time to time. Choroid plexus fulguration was the first procedure which was done, and Dandy actually did a third ventriculostomy by an open approach, and Fay in 1923 did a corpus callosal fistula. So basically, the concept was existing, but the technology was missing, and it was only Mixter who attempted the third ventriculostomy for the first time, and then it became the job of the neurosurgeons to find which patients are likely to benefit. And the early paper in 1978 from Nottingham shows you that better criteria for selection were required to make sure that more and more patients benefited from this technology. And Robert Jones from Australia, from where Charlie Teo also comes, and has started his career with Robert Jones over there. He was the first person who tried to show you that it was the congenital non-communicating hydrocephalus where the ETV worked the best, unlike the Arnold-Chiari malformation and the spina bifida patients. So today, if we look at the fact that when we see a patient with hydrocephalus, how do we diagnose hydrocephalus? I think the MR has the best way. You see the ventriculomegaly, you see the enlargement of third ventricular recess, decreased mammaropontine distance, thinning on elevation of the corpus callosum, normal narrowed cortical sulci, periventricular white matter hyperintensities, and a sign of communicating hydrocephalus is aqueductal flow void phenomena, and it would be absent if you have aqueductal stenosis. Recently, 3 or 4 years ago, I think it was 2014, when there was a very good literature review and evidence-based guidelines which the American Pediatric Neurosurgery group tried to give us, and they compared the results till that time about cerebrospinal fluid shunts versus ETV for treatment of hydrocephalus in children, and came out with the recommendation that level 2 moderate clinical certainty that both CSF shunts and ETV are equally good options. So let us talk a little bit about the technique of third ventriculostomy. There are minor differences between how we do things in various people, but the principle remains the same. You make a burr hole parasagittal somewhere along the near the coronal suture and try to get through the foramen of Monro to the floor of the third ventricle. Most people would do it under general anesthesia. Most people make a scalp flap rather than a straight incision so that the chances of CSF leak decrease. The head is elevated 15 degrees. Most of us would do a needle tap first to sample CSF, use a sheath or may not use a sheath depending on what is your status. Now, peel away sheaths are fairly expensive, so you can use a metal sheath which comes with the endoscope, or you can actually do the procedure without the sheath. Monopolar probe is a must, with you should not use with energy when you are doing the first perforation, but may be required occasionally. And Fogarty balloon is the common thing which we use for dilating your third ventriculostomy. There are differences of opinion as to what is the optimal burhole position, and people who have done stereotactically guided procedures way back in 2000. This is a paper from Mainz which showed that it should be 3 centimeter lateral and 2 centimeters anterior to the coronal suture. If you look at the Barrow paper recently, they have shown that the optimal entry point for ETV was probably more posterior than previously established. This they did with the navigation. Another paper which has come from there, which shows that more lateral you go, more front you have to come. So nearer the midline, you need to go behind. More lateral, if you make a burhole, you need to come in front. And another paper which has shown that uh, when you are actually doing the ETV, the entry point correlates usually with the ventricular size. So if you have a large ventricular size, you can literally make burhole anywhere and you can reach the third ventricular floor. But in a smaller ventricle, sticking to the standard burhole is very, very important. The other thing is unnecessarily coagulating the dura is not a good idea, because once the raised pressure goes away, the tamponade effect goes away and you can get subdural effusions and you can get CSF leaks through the wound. And to prevent that, most people, therefore, I say take a flap and try to close the dura or cover the dura with either gel foam and glue or something like that. So what are the clear features for ETV? Ben Warf, who has done a lot of work in Africa, did not have the advantage of having the MRI while doing the ETVs, and he has virtually treated all comers for hydrocephalus, and we'll talk about his work a little later on. But in an ideal situation, you should have a T2 weighted image. You should have a T2 weighted image in T1 and T2 sequences. Most patients do not require a contrast image. You should be able to see a clear evidence of ventricular non-communication and the obstructive pattern of hydrocephalus, both ventricles being large with the third ventricle being also enlarged, but aqueduct is either not visualized or very narrow, and fourth ventricle has not proportionately enlarged. You may be able to see an aqueductal anatomical obstruction or certainly a lot of lack of aqueductal flow void on T2 weighted MRI. Endoscope is passed through the sheath, the lateral ventricle is visualized, foramen of Monro is identified, and then you would be able to see the floor. And you usually puncture midway between the mammillary body and the infundibular races, and then dilate this opening with a 3 or 4 French catheter into the prepontine space. And to and fro oscillations are the best thing to make sure to give you an idea that your ventriculostomy is working well. People have used a lot of different instruments to make this opening, right from leucotome to stereotactic puncturing needles, flexible fibroscopes, fluoroscopic guidance people have used. The endoscope tip itself has been used. You have uh, the forceps being used, and some of the forceps are very well designed, especially the one which is developed by Dr. Grotenhuis and Dr. Henry Schroeder. They have a very nice way that you can pinch the third ventricular floor up and cut it away without actually damaging the basilar artery at all. And our friend in Taiwan, Dr. Tai Tong Wong, uses a Dormia basket, which the urologists use for removing the ureteric stones. Recently, the German guys have started using the thulium laser, and this can be particularly useful if you have a very thick membrane, a fibrous membrane, and a non-transparent kind of membrane, which can be very safely opened up with a thulium laser. So a typical third ventriculostomy, you should be able to see a dilated foramen of Monro. As soon as you get in, you will be able to see a thinned out floor. You go in front of the basilar artery and you make an opening. You increase that opening with to and fro movement of your balloon. You must make sure that you are seeing properly, and must make sure you are not in the subdural space, you are in the subarachnoid space, which you make sure by putting your scope through the opening and visualizing all the perforators of the basilar artery. And these are the various steps as you go through. What you need is a width of foramen has to be sufficiently large, usually about 7 millimeters, but now pediatric scopes are available, which can take about 3 millimeters opening is good enough. You should have a thin floor of third ventricle. You should have a downward bulging floor. And most importantly, the basilar should be posterior to the mammillary body. We'll see different scenarios. This is a thick floor. So what you're trying to do is go as close to the clivus as possible in a thick opaque floor. And once you have done that, you are trying to dilate this opening, and you will see very quickly that there is a second membrane in this patient, which you can virtually see through the transparent balloon. In a moment, as soon as this comes out, you'll be able to see that the second membrane had just about ruptured. Can you see the second membrane now? And then you push your scope through the first as well as the second membrane, and make sure you have a big enough opening for the third ventriculostomy to function properly. If you have a very thin membrane, a very stretchable membrane, you can sometimes, the membrane just goes up to the foramen of, foramen magnum, and you may not still be able to get an opening. So that such times, you will have to pinch the floor up, and then you will have to make an opening with the scope. Here I tried to just puncture it with the catheter itself, and I managed to open it. But otherwise, with a blunt tip of the unipolar cautery, it was virtually impossible to make this opening. Another situation is very small foramen of Monroe. So you can go without sheath, or you can just make the whole thing. You cannot then put any other instrument. So here we went ahead, and this was a minoscope with which you can actually perforate the floor quite well. We've gone through one layer and the second layer, and you can see the basilar perforators quite well. So once you're sure where you are, you can actually do this fairly safely. This is another spina bifida patient, small foramen of Monroe. As you will see, in fact, virtually the foramen of Monroe was closed in this patient. You can see atresia of foramen of Monroe, but there is a spontaneous septostomy that has happened. So even though I have entered from the right side, I decide to go to the left side after making sure that there is no possible entry into the third ventricle from the right side. I have decided to go through the left side here, and from the left, once I have gone through the septum onto the left side, I can visualize the third ventricular floor quite well, and then I can do a third ventriculostomy reasonably well. So you need to innovate a little bit to do that. When there is a very narrow space between the clivus and the mammillary bodies, what will you do? You go as close to your clivus as possible. The only danger in that is you might sometimes enter the subdural space rather than entering the subarachnoid space. Here you can see there is a small opening here which shows that there's a kind of a spontaneous ETV that has happened, but you need to enlarge it because there is no flapping, or the second membrane is probably stopping it. So we are opening into the narrow space there, and I'm trying to direct my instrument towards the clivus rather than towards the basilar artery. And once I have done that, then I would put the balloon to dilate it. And now you can see the to and fro movement, and the whole cavity is seen now, and the pulsations of the membrane are seen as well. When the opening occasionally happens posterior to the basilar artery, you need to correct that. You need to come out immediately. Do not dilate, do not damage the perforators. Immediately make another opening, or you can enlarge the opening with the scissors or the Schroeder's forceps. Very small space here. Trying to dilate the space when I realize that I am posterior to the basilar artery, and stop there itself. I feel I am not in the proper space. I see that the perforators are all in front of me. So then I go further and I make another opening close to the clivus and then dilate that opening to make a bigger opening there. So basically the clival line serves as a very important anechoid landmark, and I think it is a very good tactile navigation for you to do a third ventriculostomy very safely. And I think I find this to be one of the most important landmarks, especially in a country where I work, where I need to use third ventriculostomy several times in post-infective hydrocephalus, where the landmarks are not so commonly seen. Clival line becomes a very important landmark, as you will see later on with a few cases. Another thing that can help you in a very difficult situation, like here in a scarred third ventricular floor, we had no other recourse to the fact that we had to use navigation. You can see the several scarring into the prepontine space, but with the USG guidance as well as the navigation guidance, we have been able to get into the third ventricle as well as into the uh, prepontine space quite well. So these kind of equipment can help you, but you still need to be very, very careful when you are doing it in a when the membrane is not transparent and we are not sure of your landmarks. Endoscopic third ventriculostomy can also be done with a fiber optic endoscope, and especially this is, I think, for uh, third ventriculostomy, it may not be so important, but if you want to do a choroid plexus coagulation or if you want to do an aqueductoplasty through the same opening, this can be extremely useful. What are the unfavorable features for ETV? I think if you have a structural anomaly which are impeding the procedures, if you have AVM or tumor obstructing the floor, if you have enlarged massa intermedia, if there is really insufficient space between the mammillary body and basilar and clivus or basilar artery ectasia, you should probably not attempt it. A feasible alternatives to do standard third ventriculostomy described by Dr. Subodh Raju, one of our colleagues from Hyderabad, and also by Joachim Ortel in Germany, is the lamina terminalis third ventriculostomy, which is the second option, and you can get into the interhemispheric fissure like the basilar artery, which you see in the general ETV. You will be able to see the anterior communicating artery when you go into the interhemispheric fissure. I have personally not very great experience with this and do not have a video to show. When do I abandon the third ventriculostomy? When the post-inflammatory distortion of the ventricular anatomy does not allow me to be certain that I am going to reach where I want to reach, I can probably, I would like to abandon. If you have a very thick ventricular floor, I think it's a good idea to abandon. When you find that as soon as you enter the prepontine space, you see that it is obstructed by scar tissue, there is no further point in keeping on dilating and trying to get it. Bilateral absence of furon of Monroe can actually be a contraindication, but as I have shown you in one case, you can do a septostomy and may be able to perform the procedure. And of course, poor visibility due to cloudy CSF is a definite no-no. There is a lot of discussion about in which etiology third ventriculostomy is successful and at what age. And this is a very good paper which has shown you that even in very small children up to 3 months, if you have purely obstructive hydrocephalus like congenital aqueduct stenosis, it works quite well. Usually children about 6 months with obstructive hydrocephalus of any kind, I think, are extremely good candidates. It is a safe procedure to do even during pregnancy, as this paper has shown with 5 pregnant women. What about spinal dysraphism? Robert Jones had shown this. Grotenhuis has also shown it in his study. And later on, Charlie Teo has shown in another study that primary attempts at doing third ventriculostomy are not very successful in infancy. But if these patients present with shunt malfunction at a later age, and what we call now secondary ETV, if we do that in these patients, it can be successful, especially if the pattern of hydrocephalus appears to you to be more of obstructive pattern. And these are actually the figures that they have shown what are the success rate of what is called a secondary third ventriculostomy in these patients. Similarly, Grotenhuis has very classically shown that the primary success rate in his patients was only 23%, while whenever he did as a second procedure, after a primary procedure was done elsewhere and he had to do it for blockage of shunt, the percentage of success was as high as 77.8%. Tumor-related hydrocephalus, ETV works very well. Should it be done in every patient? This is being debated quite often. In Europe, there are a lot of centers where ETV is done as a preoperative measure with the feeling that post-operatively these patients will have less CSF leak and less need of shunts. But the general percentage of post-operative hydrocephalus in such patients is only about 10 to 14%, and therefore a lot of your ETVs will go waste, and we do not do it as a regular procedure. I think all the three papers I am showing you are from Europe, which have shown that it has given them a big benefit. In our parts of the world and in Africa, I think one of the most important consideration is, can we use endoscopy in the management of patients with tubercular meningitis? And it seems that you can use it in chronic cases once the acute disease has burnt out. And the main reason for that is that there are a lot of basal exudates. And as I showed you in that child, similarly in here, you can see exudates in the prepontine space which do not allow you to be successful. While if you do it in a treated patient, you should be able to see some tubercles, etc., which are probably healed, but you are able to make a third ventriculostomy fairly well in such patients. And if you get a good uh, flapping membrane, it is more likely to succeed. Uh, the African guys, the Cape Town guys have actually shown that this can be found out by pre-operative method of just injecting a little air in the in the lumbar space. If you see the air getting into the lateral ventricle, that means it is communicating hydrocephalus, and you should go for a shunt. And if you do not see any air in the ventricle at the end of 1 hour, you should presume that it is obstructive hydrocephalus and try out a third ventriculostomy. Something similar, depending on how you find that the patient has communicating or non-communicating hydrocephalus, you should consider ETV according to the Velour group as well. And there are there are in fact 4 major studies now from India which show that in acute phase you have about 30% chance of success, while in chronic phase you have a chance of more than 70% success. In these are the various series, in fact more than 4 series. What is considered very important, which Chinali has brought to the fore, is that the radiological anatomy, whenever you decide in a shunt failure patient that would he be benefited with what is called secondary ETV, you should see their ventricular anatomy. If the ventricular anatomy shows you that the lateral ventricles and third ventricle are bigger than fourth ventricle, and you have a reasonable good prepontine space, you should probably give everybody a chance to go for a third ventriculostomy. And the radiological evaluation is probably the most important part even in post-meningitic hydrocephalus, like we just discussed. So this is one patient who came to me with a shunt failure in a very bad state actually, and you can see that uh, there is a scarring here. This girl has completed her treatment with anti-tubercular treatment, and here I have been able to make a clean opening into the prepontine space, again with the and we usually make sure that it is working by what we call the cinecysternography, which we do after about 3 months. What about pyogenic meningitis? Not as a primary procedure, but this is a child who came with actually a shunt insertion. The shunt insertion got infected, so we first treated that. And after the shunt infection cleared up, by that time the child was about 4 months, we decided to go ahead and do a third ventriculostomy. And this has worked quite well for now more than 4 years follow-up. He has not required any further procedure and has grown quite well. So in pyogenic ventriculitis, you do not get so much of basal cisternal scarring, and you can be good after you have completed your antibiotic treatment. I think Abhay Kulkarni has come out with this idea that depending on the age, etiology, and previous shunt placement and the age of the patient, you can score them. And usually if you have a better than 50% score, you can advise the parents or the child that he should probably be given a chance to do a third ventriculostomy. And I think less than 50%, you would like to avoid it. though you have to leave it to the patient. There are many patients we see in India over a period of time with social media talking too much about third ventriculostomy, want that to be done as a first procedure. And after counseling them, we have actually done third ventriculostomies up to an age of about 6 weeks or so. There is a feeling that the ETV score may not be completely faultless, and people have shown that acute elevation of ICP reacts better to third ventriculostomy than a chronically raised pressure. And this has been shown actually in a series of about 60 patients in California. We actually wrote up a review for this recently as to what is the success and failure and what is the role of secondary ETV, which have been published recently in Journal of Pediatric Neurosurgery, the US Journal, and the Korean Neurosurgery Journal. We had an experience of 36 patients at that time, where we had almost 70% success rate when patients were treated when they came with a shunt failure. There are certain additional procedures which you may be done to help the patient. In patients who have blocked shunts and the fourth ventricle is enlarged, we perform an additional aqueductoplasty. Like in this patient, the third ventriculostomy is just about getting over. Once you have seen the basilar, you come out, you go a little posterior, and you will dilate this only with the ventricular catheter, and then usually we leave the catheter in the fourth ventricle, and if it is not draining well, then connect it to a shunt later on. Choroid plexus coagulation became very popular with Ben Warf's work in Uganda, and it showed that ETV plus CPC gave a much better result of 66% follow of 66% success compared to 47% in post-infective, post-hemorrhagic patients. And actually, Abhay Kulkarni has studied these patients on a long-term follow-up and have shown that their overall development has also not suffered. But a similar experiment done across 9 centers in United States by the hydrocephalus research group has shown that it has not given superior results compared to shunts, and therefore how much CPC helps is still a matter of consideration. However, one thing is very clear, that the not so good results of CPC may be associated with the fact that unless you use a fiber optic scope, you cannot do a very good choroid plexus coagulation, which Ben Warf used to do. And that still remains a consideration. If you want to do CPC, you should do as extensive as possible. I think when you have acute ventriculitis, which is a common problem in very young children, endoscopic lavage can give you a lot of relief, and a ventricular catheter can be kept, like our friend from Malaysia has advised. And in Europe also, it is becoming popular for post-hemorrhagic hydrocephalus, that ventricular lavage gives you much quicker chance of treating the hydrocephalus, and many patients do not require shunts. If they require shunts, they do not require so many revision of shunts, which is a common thing to happen in post-hemorrhagic, post-infective hydrocephalus. In complex multiloculated hydrocephalus, it works beautifully. I think endoscope is extremely useful to do septostomies, to do several fenestrations. Like in this patient, we first did a septostomy because both ventricles were not communicating, injected dye, made sure that they started communicating, then actually went for ETV. And in this patient, we could delay the shunt insertion for a fairly long time, and patient was managed only with one shunt eventually. So, and we usually make sure in multiseptate hydrocephalus that we have reached all corners by injecting a dye towards the end of it. I have recently written a review of this in Child's Nervous System, which you can probably have a look in the yearbook. So I will end here, and we're happy to take any questions. John, is everybody
Okay.
awake?
Yeah, thank you. No, of course. Thank you very much, Chandra. Thanks for taking the time. Okay, the floor is open for questions or comments for Chandra.
Excellent video. Hello, can you see me?
Yes.
Yeah, we can hear you.
Yes, I.
Yeah, excellent video. A lot of experience there. We use this ETV quite often now. I believe that taking the CSF away from the ventricular system is not a great idea. I believe that the CSF in the ventricular systems is in a production phase, and the CSF in the cisterns is what helps with the cleaning and cooling of the brain. So we had hypothesized it in 2010, and then from 2007 I've been proposing that the CSF goes into the brain. It is the CSF that goes into the brain to produce CSF shift edema, which can be addressed by cisternostomy. Then our studies and things led us to believe that CSF actually goes into the brain to do two things. One is cleaning, that happens only in the night. That is aquaporin 4 dependent, and that happens only in the night. So, but cooling, CSF also goes in for cooling, and that happens all the time. So we wrote this up as a Springer Neuroscience's annual series chapter, and it's been published about 2 years back. Now there's a lot of evidence for it. Now, the thing is, if you take out ventricular CSF with a shunt, you're actually giving less chance for the CSF to reach the cisterns, and thereby you're creating a problem where CSF, the brain is not cooled and cleaned. In another, if you ask me how we further expanded this, if you see, this is also related to endoscopic surgery. All our sinuses, they are all lined with wet mucosa. So when you take a breath, actually what happens is, it is like a wet cloth hanging in a room. So when you take a breath, what happens is these sinuses, the mucosal water, they evaporate, and then they give away latent heat of evaporation, and therefore the sinuses start cooling. And if you see a heat graph of the face, this area is characteristically blue. You see that cool. And the largest cistern is the suprasellar cistern, and it is right in the center of these sinuses. It's amazing, and all the vessels travel to the brain from the suprasellar cistern, and all the vessels, they have a hole around them. They have a small pathway around them, and this pathway is called the Virchow-Robin spaces. So, and again, these vessels are pulsating. So when something is pulsating in a channel, it drives the CSF up. It's not this. It is not the capillary flow. It is something called the Archimedes screw principle. So it's pulsating, and therefore the CSF is driven in. You see what a beautiful system. It's cooled by the sinuses, and this cooled sinuses by convection cools the suprasellar system, and then therefore this is pumped up into the into the brain, and this cooling happens all the time. And then cleaning happens in the night. So this cleaning and cooling, if it's not taken care of, we propose that diseases like Alzheimer's, diseases like other degenerative diseases, all this starts happening. Even punch drunkenness, all these happens actually. So then we started proposing that it is actually maybe not a great idea to shunt the CSF away from the brain into the abdomen. So we're trying our level best. Of course, we really don't know what happens after the shunt, because we're not really looking at these patients on a terms with very, very strict ways of looking at their development and their mental score and things like that. So I think ETV is a very natural way of doing things.
Well, I think it certainly avoids expensive shunts. It comes to a level of equilibrium which no shunt can actually ever give you. and shunts are becoming more and more complex, more and more expensive. I think that if you can avoid, it is certainly a worthwhile idea. The only other question which comes to my mind, especially after what you have said, reducing CSF production by choroid plexus coagulation may also have some harmful effect because less CSF production and especially the kind of chemicals that probably are secreted along with that, lesser concentration of that can also be deleterious to the interior milieu of the ventricular system or the brain itself. So I'm not sure if CPC is all good.
Yeah, absolutely. Absolutely. Yeah. I think the natural way of the ventricles being the production center and the cisterns being the center where cooling and cleaning is, is done, to maintain that, the best physiological procedure would be ETV. And I think it should be it should be in the armamentarium for every single surgeon. Of course, there are sometimes you just cannot do it, very rarely, but I think most of the time you can get away with an endoscopic third ventriculostomy.
Sir, Sir Deopujari, sir?
Yeah,
Hello?
yeah, go ahead.
Sir, is there any use of ETV in post-traumatic hydrocephalus?
A very good question. I think we really don't know. I think in post-traumatic hydrocephalus, you have 2 or 3 mechanisms. Is volume loss part of the mechanism? Then it is unlikely to help. Is it due to the subarachnoid hemorrhage that happened at the time of the injury and later on it has manifested like what happens in NPH kind of a syndrome? I think it can help. How it helps is certainly not known, but given the same analogy as the normal pressure hydrocephalus, many people feel that these are patients who had some kind of a compensated hydrocephalus and something triggered it off, like the minor trauma maybe. So those kind of patients may benefit, but I think generally in a post-traumatic hydrocephalus, it may be in post-traumatic hydrocephalus. Can you hear me?
Yes, sir. Yes, sir.
Yes, yes, yes.
In post-traumatic hydrocephalus, if it is due to scarring of the basal cisterns, and then it is unlikely to be very helpful.
Yeah, again, one thing in post-traumatic hydrocephalus I would like to say is most of the time people use decompressive hemicraniectomy, which is actually, I would say it is, I mean, forgive me for being strong about this, but I think it's a criminal procedure. It's not physiologic at all. It's, I mean, the brain is swelling because of CSF shift. That is why you don't find any CSF in here. And if you allow this brain to be herniated out through that decompressive hemicraniectomy, you just converting a cemetery into a vegetable market.
Yes.
So yeah, so there's been so many studies, and we all know how to open cisterns. It's a bit difficult, of course. It's not, I mean, now there's a lot of guys doing this opening cisterns and they're finding things. So I mean, they're finding it not too difficult. I mean, of course, my mistake was to make it too difficult. But then after Roy, Wang, Parthiban, and rest of the guys put in their ways of doing cysternostomy, now things have become very simple, and there's a lot of papers, and yeah.
I'm interested in knowing you have followed up your patients now for quite some time.
It's 10 years now.
So is the incidence of hydrocephalus much less?
Yes, much less. Yeah, this is exactly
to...
what. Yeah, this is exactly what I wanted to tell you. Our incidence of hydrocephalus is much less. I mean, we find that for the DZ patients, it's almost 20%, while our hydrocephalus is less than 5%. So this is what I wanted to tell you when Gautam had raised the possibility, I mean, the probability of this ETV being used in post-traumatic hydrocephalus. I wanted to tell him that maybe the primary procedure itself should be changed rather than going and treating a complication which happened because of the primary procedure.
Yes, sir. We are advocating your cystonostomy. We started doing it.
Okay, excellent, excellent.
Other questions?
Don't be shy.
Hello, sir.
Yes.
Sir, any fixed measurement like pre-pointing system, this much measurement should be there before doing ATV. You measure it on the MRI prior to taking up for ETV.
Can you just repeat again?
Sir, any fixed cutoff for that pre-pointing system? Any measurement you take before prior to doing in the ETV?
No, the measurement is not described, but you shouldn't have on a T2 weighted sagittal image, you can usually see the basilar artery very clearly in the prepontine space, and you should be able to see some CSF between the basilar artery and the posterior edge of the clivus.
Okay.
I think even if you see a thin film, I'm usually okay with it. You can displace the basilar artery posteriorly, but you need to get an opening there. So you should see some CSF between the basilar artery and the clival dura. The other thing, of course, is that how high it comes and where does it bifurcate. Sometimes if you have a very tortuous artery, then you may not be able to get entry, but luckily it doesn't happen very often, especially in children.
Okay, sir. And regarding any evidence, sir, of ETV used in NPH, any success rate?
ETV
Your
in NPH,
experience?
the highest success rate is actually in Gangemi series from Naples in Italy, who has shown virtually more than 60% success rate. And the other guy who has shown a good success rate is Dr. Oi from Japan. And both of them are very sure in their feeling that this is a different kind of hydrocephalus. This is a hydrocephalus which has been sort of chronic but not apparent occult hydrocephalus, which becomes manifest for some reason in the late age. And when that happens, third ventriculostomy works. These are not patients who otherwise we call communicating hydrocephalus due to various other diseases which produce normal pressure hydrocephalus.
Thank you, sir.
Okay, more comments, questions?
Prof, regarding the post-operative period, unlike the patients who had shunt, where we see the radiological findings are more favorable, how long do you wait until you say that this ETV is not working and the patient maybe needs a repeat procedure or a shunt radiologically?
Right. Very, very, very important and very practical question. I think the most important thing which tells you that your ETV is probably not working, especially in young children, is the CSF leak from the wound. The earliest sign that it is not working, you will find some swelling at the site of your burr hole, or you'll probably find a few drops of CSF coming out. The initial response to this is that, especially in very young children, that the subarachnoid space is not prepared to take such a heavy load of CSF, and therefore do daily lumbar punctures. And most people in pediatric neurosurgery practice do 2 or 3 days daily lumbar punctures on these patients, feeling that the overload of CSF is taken away and the subarachnoid space gets used to increase CSF and starts absorbing it. But if it doesn't work beyond 3 days, then you have two options. One option is to go back and see if your stoma is still open. If the stoma is closed, then you need to reopen it, of course, by doing a redo third ventriculostomy. If the stoma is open, then your best bet is to just put in a shunt and probably hope that it will work till the child is big enough to take care of his CSF in the cisterns, and you can probably reattempt a third ventriculostomy after the child is older. What we do is we usually do not immediately rush in to do a repeat third ventriculostomy or endoscopy inspection. We usually, through the same burr hole, whenever we are in doubt, especially in post-hemorrhagic, post-meningitic patients, at the end of the third ventriculostomy, I leave a Ommaya reservoir. And in that reservoir, we inject 2 cc's of dye. this urographene or the what's the other dye which we use, metrizamide or omnipaque. And you take a scan after 1 hour. You usually find the dye has gone into the subarachnoid space if your third ventriculostomy is open. By 6 hours, it usually goes out of the cisternal system and you do not see it on the scan. If it is still persistent after 6 hours, you know that your ETV is working, but your cisternal absorption is not good. And I would usually put the shunt the next day in such a patient.
Thank you. Thank you so much.
Okay, any more comments, questions? Okay, Dr. Deopujari, thank you very much. And tomorrow, do you know what the topic is going to be?
Tomorrow we can do some tumors, what we can do with endoscope. Maybe the minimal invasive endoscope assisted microscopic approaches.
Yeah,
Okay.
yeah.
Yeah.
I can also show a case for tomorrow and let Chandra show the rest of the case. I can show probably telovelar meningioma, so a posterior third ventricular meningioma. So maybe that would be about 5 minutes or 10 minutes. And
So you can start off and then I'll take over Ayub if it's okay.
no, I can wait for you to finish and then I can.
Whichever way it's comfortable. Okay.
Okay, thank you very much, everybody. And we'll see
you
you
so much.
tomorrow.
Yeah.
Thank you.
See you
Thank
guys.
you.
Thank you.
Thank
Thank
you.
you.
Yeah, thank you.
Thanks,
Okay,
Zaid.
very good. I'm just gonna leave the room open.